there's two different types of anorexia nervosa. We normally separate the restrictive subtype. So those are people that are purely restricting their behaviors in terms of eating. And then there's the other type of anorexia, and that's a binge purging subtype.
G'day, and welcome to Wellbeing. I'm Jack Hodgins. Today is the second instalment in our series on anorexia, continuing to look into anorexia from an academic perspective. We are talking with Professor Isabel Krug from the University of Melbourne. Professor Krug is a senior lecturer in clinical psychology and leads the Eating Disorder Lab based at the University of Melbourne. The main focus of the lab is to improve the understanding of the genetic, neurocognitive, environmental and psychological underpinnings of eating disorders. Professor Krug is now on the line to share her knowledge on anorexia. Hello Isabel, and welcome to Wellbeing.
Oh, hello. Hi, nice to meet you.
Many have heard the term anorexia, but what actually is it?
Anorexia is a mental health disorder. It's classified according to the Diagnostic and Statistical Manual for Mental Disorders, and it's characterized mainly, just in very simple terms, by distorted body image, emaciation, fear of weight gain, self-starvation, and also an unwillingness to maintain a healthy body weight. So as I said, it's the DSM that actually classifies the eating disorders. So there's been quite a few changes because we used previously DSM-4, so now we are with the 5th edition since 2013. The previous edition, the DSM-4 revised, did have quite a lot of focus and emphasis on weight. In anorexia, the DSM-5 level, it doesn't that much anymore in terms of the main diagnostic criteria. So basically, the main diagnostic criteria for anorexia is persistent restriction of energy intake that then actually leads to low body weight, but the low body weight is not that really defined in this DSM-5 version. And the second criteria would be to have an intense fear of weight gain or persistent behavior that interferes with the weight gain. And then the third main criteria is that there's disturbance in how weight and shape is perceived due to weight and shape on one's self-evaluation. And then there's also lack of recognition of the seriousness of the current low weight. There is a severity spectrum in the DSM-5 that actually classifies eating anorexia patients into severe and extreme severe, and that's based on BMI. But there's actually not really any empirical evidence to suggest that those different, I think there's 4 different severity classification categories based on BMI, that they're actually the best way to assess severity. Also, it's important to note that there's 2 different types of anorexia nervosa. We normally separate the restrictive subtype. So those are people that are purely restricting their behaviors in terms of eating. And then there's the other type of anorexia, and that's a binge purging subtype. So they basically, on top of restricting their food intake, they also have binges and purges on a regular way. So that would be kind of once or twice a week. For instance, the difference there is between anorexia binge purging and bulimia, because many people then would think that's bulimia. But the difference between anorexia binge purging and bulimia is mainly the body weight. So anorexia nervosa binge purging are normally underweight, whereas bulimia patients are normally in the more normal weight range. I think a lot of people probably don't know that there's the restrictive and binge purging subtypes, and they're quite different if you then think about them in psychological terms. So the binge purging type is a lot more impulsive psychologically and much more similar to bulimia, versus the anorexia restrictive type is a lot more harm avoidant.
How prevalent would you say anorexia is?
Actually, if we consider it overall, it is considered to be a low prevalence disorder. So there's a lot of different lifetime prevalence rates of anorexia in females, but roughly, just to give you an estimate, one international study, for instance, found that it's between 0.3 and 1.5 for females, and for males that prevalence rate is a bit lower, so between 0.1 to 0.5%, but I have to say that males are often unrecognized because people and clinicians might think it's a female disorder, so probably it's not recognized as commonly in males. And there's data suggesting that it's actually on the increase in males.
What is the usual onset?
So normally anorexia begins in early adolescence and early adulthood. Normally the difference between anorexia and bulimia is that the age of onset for anorexia is a little bit younger than for bulimia. The majority actually are diagnosed before 20s. A smaller percentage is diagnosed before age 10, for instance. But we do see always more and more also presentations outside of those age ranges. So that would be a very early age of onset or also a late age of onset. So women in their 40s or so presenting with anorexia and other eating disorder. So we do see both extremes are also more commonly. But I would say the general age of onset would be adolescence and adulthood. And obviously there's something about puberty that triggers the onset of an eating disorder, and that's to do with changes in the body and obviously developing, I guess, secondary sexual organs, and many women wanting to not present as a woman, and kind of that maturity fears, and so they kind of try to restrict their intake to have that more childish-like appearance even in their teenage years or in their early 20s. So yeah, puberty is a really common risk factor.
What are the reasons that people develop anorexia?
That's a very good question. I wish I could tell you exactly and pinpoint to you, this is the main reason. There's a lot of reasons. It's different for every person. So it is considered to be a multi-factorial illness. So there's a genetic contribution, and then there's quite high. People, I think, underestimate the genetics of it. So we have seen that eating disorders run in families, but not just an eating disorder, but it could also be any other mental health illness that runs in the family. And there's been quite a few twin studies as well that have seen that the concordance rate one eating disorder is higher in the monozygotic twins that share 100% of their genes than the dizygotic twins that share about 50% of their genes. So yeah, genetic, and there's of course also social factors. So I guess the drive for thinness in terms of the thin ideal and women wanting to be thin, and that's being portrayed by the media more and more. I think social media is also a really important risk factor at this moment. It used to be more traditional media, but now everyone is obviously turning to social media. There's also there could be other risk factors such as stressful life events, sometimes trauma. It could be abuse. It could be bullying at school. So I guess this could be all termed as stressful life events. And obviously there are also quite a lot of psychological factors. So we do know that there's some personality traits that are really elevated in eating disorders, such as high perfectionism, and in the binge purging subtype, as I mentioned before, impulsivity. So there's the social component, the psychological component. Obviously, we don't know exactly what triggers an eating disorder, and we're doing lots of research on that, but it's really hard to know, because some people might have been exposed to some of these risk factors and never develop an eating disorder, and other people might have been exposed to maybe just one or maybe none of those risk factors, and then they go on to develop an eating disorder. Yeah, it can be tricky to say who develops an eating disorder and who doesn't. But yeah, overall, there are some major risk factors that we know are really important. And I mean, from the meta-analysis, we know that the major risk factor and the most proximal ones are dieting and also body dissatisfaction.
How drastically can a diet change when someone develops anorexia?
It can change very drastically, and obviously it depends again from person to person. I mean, it just starts with cutting out certain food groups that maybe that person considers as being high caloric content. But that obviously might not be enough, and then they continue cutting out other types of food. But it's not just about cutting out foods and having a less balanced diet. It's also about how they are engaging with food. So they might not really enjoy eating in front of other people anymore because they might have specific rituals, how they might be consuming the food. They might maybe divide the food based on specific, characteristics of the food. I don't know if it would be color or shape. Yeah, maybe that could be potentially not enjoyable with other people. So they actually start also eating in solitude. They kind of engage less in social meals. So yeah, there could be really drastic changes in terms of how somebody with anorexia would kind of consume food. Obviously, they count their calories. They would go to the supermarket and know exactly how many calories each food has. Would probably say, that they want to eat healthy food, but the main reason for consuming the healthy food is not because of it being healthy, but because it has less calories. Often they might also say that they could potentially have develop a food allergy, and then they are, gluten intolerant, and so that is kind of allows them to cut out even more food items, and I guess they wouldn't have to provide any kind of justification for other people if they were able to say because of the food intolerance they can't eat certain items. So those are things that we commonly see in individuals that develop anorexia or already have anorexia or any other eating disorder, basically.
Does anorexia look different in children that have it than, say, the older kind of population that has it?
That's a good question. Actually, I must admit I haven't worked too much with children. I've been working more with adults, so it's probably not in my expertise to be able to clarify exactly how it might be different. I mean, I do know that with the children, it's really, really important to involve the family. But I think overall, I would think that the actual presentation of the illness could potentially be quite similar in terms of what I described right now, in terms of cutting out food items, eating in solitude. I mean, the diagnostic criteria would also apply. I mean, the BMI severity index, you couldn't apply that to a child because they're still growing, so it wouldn't make sense. They use more percentages, to my understanding, so it's a different type of way to obviously classify severity. And obviously the treatment would be really, really different because you do have to include the whole family. In adults, also cognitive behavior therapy has been considered to be effective.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is Professor Isabel Krug from the University of Melbourne, where we are discussing anorexia nervosa.
How long does it take for someone to develop anorexia? Does it happen gradually?
It's really hard to say. Some people, could just go into a diet for whatever reason, or might be dissatisfied with their body, start a diet, and then they develop an eating disorder really, really quickly. Other people could potentially have already disordered eating symptoms for quite a while, so they might have been on the restrictive spectrum for many years, and maybe they had more what is commonly known now as also in terms of these orthorexic tendencies, in terms of health, eating really, really healthy food, and then because of a specific life stressor, they then can't keep that up into kind of on a level that it's not dysfunctional anymore, so that they actually then go and develop an anorexia, because I guess it's mainly also about whether it's impacting their lives and their functionality, and then they need to seek treatment. So again, I think there's really big variation in terms of how long it might take for someone to develop anorexia. Also, it often doesn't stop with one illness because we do know that the eating disorders cross over. So we do know that, for instance, anorexia, there's quite a high chance from anorexia crossover to anorexia binge purging, and then from that to bulimia. And maybe then it is also possible in the recovery process to then cross over to residual eating disorders. So that could be otherwise specified eating and feeding disorders, and these would be subthreshold kind of illnesses, but that could still impact the person's life, and they require treatment. Somebody might have subthreshold symptoms initially and then develops a full-blown anorexia or other eating disorder diagnosis. So we've seen a lot of different types of presentations. Yeah.
What kind of impacts does anorexia have on, say, the internal organs or the heart?
It does have a lot of impact. It has, as I mentioned, also very serious physical, psychological, also emotional consequences if you obviously have a very severe long-term eating disorders. Most of them are actually reversible following recovery, which I think is a good sign, but there are some consequences that could potentially be life-threatening. So in terms of the physical ones, just to mention a few, there could be abnormal blood counts, there could be fatigue, there could be insomnia, there could be dizziness or fainting, there could be hair that thins or breaks or falls out, and also this laguno hair that develops over the skin. In terms of these abnormal blood counts, well, what we normally see is like electrolyte disturbances, which I guess can cause this weakness and tiredness, but it can also cause other mental health problems, so depression, and that then can result actually in cardiac arrhythmia and potentially also in sudden death. And there's other physical consequences actually, so you could have osteoporosis, so the bones of somebody that has had anorexia for many years is very fragile, so they have a lot of they break the bones quite quickly. Often it's compared to an older person. The kind of the bone skeleton of anorexia could be compared to somebody at an older age level. That's because of the malnutrition and the impact it has on the body. Often also people with anorexia do suffer from infertility. As I mentioned, quite a lot of these can be reversible, but not necessarily all of them. Also, if somebody has the binge purging symptomatology, obviously that kind of symptomatology also affects the heart. That's done even. I think that the presentation with anorexia binge purging could potentially be having even more physical consequences than the anorexia restrictive alone. But it obviously depends on the degree of severity for each individual patient. So I can't really generalize that in that sense. Yeah.
Does anorexia cause delayed puberty or loss of fertility?
Yes, there are studies that have shown that it might be, because one of the main criteria in the previous diagnostic statistical manual was amenorrhea, so that's loss of the menstrual cycle. It's now not included in the DSM-5 anymore. That was because a lot of anorexia patients might have been put on the contraceptive pill, and then they would get their period, but that was because of taking the pill. It does definitely also impact the reproductive organs, and there are patients that have had problems with infertility. In terms of delayed puberty, it would probably most of the age of onset would be during puberty or after puberty. But if that onset was before puberty, yes, of course, it could delay the onset. But I think we don't have enough research studies that actually have been able to show that. We do know that puberty has an impact, but whether somebody presented with an eating disorder before puberty already and then it was delayed, we don't really know for sure, but I could imagine definitely, that it would have an impact,
Why is anorexia more common in females than males?
So there is about 10% of those diagnosed with anorexia are males, so it's a 1 to 10 male to female ratio. I guess some people actually suggest, as I said before, that it's actually underestimated because it's more thought to be a female disorder rather than a male disorder. So probably males go undiagnosed. I think there's been a really big push in the last couple of years to improve diagnosis and treatment of males with anorexia. And but actually the research that also we've done in the previous clinic where I've worked, we've compared presentation of males with an eating disorder to females, and the presentation is quite similar. One aspect that is probably different and really important is there isn't so much of drive for thinness. There's probably more of a drive for muscularity because men strive to be more muscular versus the women want to be thinner. And 3 or 4, a couple of years ago, we didn't have the right measures to assess that, but now there have been a lot of measures that have been validated to assess drive for muscularity. So I think that's probably the biggest difference between males and females presentation, and the body dissatisfaction is slightly different. And also they say that maybe the age of onset could potentially be a bit higher in males than in females, but again, we might not potentially have the right studies to show that. Why it is more common in females than in males, that's a really good question. I think most of the risk factors could still apply for the males that we found for the females. It's probably just considered to be a more female disorder from the beginning, and maybe we have underestimated the prevalence rate for males, and it is increasing, I think. And I think we don't really know exactly why it might be affecting women more than males. Maybe that in the past, women have had more pressure to have competing roles, so they need to be thin, they need to be successful at work, and they also, when they have children, need to take care of the children, versus maybe the males didn't experience as many pressures. Obviously, society is also changing, so I don't want to kind of stereotype that, but in the past, maybe the males would be not having to take on so many multiple roles, and so maybe potentially not experience as much stress as the females. That could be one reason. It's a bit of an outdated kind of theory, so I think we probably need to consider more up-to-date theories for the gender imbalance here.
Can someone's lifespan be affected by it?
We do know that there's a higher mortality rate on people with overall eating disorders, and especially anorexia. There's research that potentially shows that up to 20% of anorexia patients could potentially have a fatal outcome, and a high percentage of suicide. Actually, it's the mental health problem with the highest rate of suicide amongst all. In terms of the lifespan, that's a good question. I don't know if we have enough studies for that, actually. It's really hard to get those types of studies because you actually have to follow up the clients for the whole life, have to follow them up until they're in their 80s or 90s, so we don't really know. I could imagine if they get the right treatment and it's being treated the illness on time, potentially not necessarily, but obviously if somebody presents with the illness for many, many years, and there are some obviously that have a chronic anorexia, or some that even have the resistant anorexia, which or have lots of kind of relapses. As I mentioned, there are a lot of physical consequences, so I could imagine that definitely has an impact on the body overall. But again, I don't think we have enough studies to really be able to answer that question.
How should we frame anorexia? Is it a disorder, a disability? Like, where are we at with that?
That's a good question. I mean, it is part of the DSM-5. So the DSM-5 is about mental disorders, so it does define it as a disorder. But I mean, I guess it could also be phrased as a disability. I think every type of mental health illness could be phrased as a disability. So because it impacts the person's life and their functionality, and I think that's what obviously a disability does. So I think probably both could potentially be appropriate. Again, it probably depends on where you're living and what funding you might be getting, depending on what terminology you use. So I know, for instance, in America, it's really important that a patient that attends a hospital gets the classification of a disorder in the DSM-5. Otherwise, the insurance doesn't cover the treatment. I guess Australia is probably a bit better in that sense. It still would need requirement, I guess, to get this kind of Medicare rebated session, which I mean have increased in the last couple of years since they increased the numbers of sessions for eating disorders. So I don't know if with a disability you would be able to access those rebated sessions. I think you'd probably have to change the whole health system in Australia, because then you would have to consider all other mental illnesses similarly. You can't just consider the eating disorder like that, as I guess it could potentially be quite a difficult changing in terms of the definition, in terms of what impact it could have on treatment access to the person, if that makes sense.
You're listening to Wellbeing, a nationally distributed radio show and podcast. My guest today is Professor Isabel Krug from the University of Melbourne, where we are discussing Anorexia Nervosa.
I think something that people, and some people may be listening and may have this kind of view, is that a lot of people view anorexia as something that's almost self-inflicted, but really that's not the case, is it?
No, it's not. No, definitely not. And we do have a lot of studies that have shown that it's not. I mean, that's why I also highlighted the genetic component. It is an illness. So, I mean, I don't know, but maybe that's why you asked me the difference between the disability and the illness. I mean, if you regard it from that point of view, then of course it would be important to consider it as an illness. And I think there's even some mental health professionals that have a bit of a stigma against eating disorders and think it's self-inflicted. And we've done studies on that as well that have shown that, yeah, it's definitely not the case. I think there's a misunderstanding as well from the society and also mental health care professionals that don't work that much with eating disorders. They don't really know that there is this big kind of biological component as well. So it would be similar to working with somebody that has a depressive disorder or has schizophrenia, where we also know that the biological component is really, really high, and it's not somebody that chooses to have an eating disorder. It is definitely an illness that needs the same type of treatment as somebody that might have schizophrenia, for instance, or autism, which also has a high genetic component. So yeah, there's definitely misunderstanding about that, I think.
What research still needs to be done in the field towards anorexia?
Oh, a lot, actually. I don't think there's enough research at all. Actually, I think we are really far behind from any other type of mental health illnesses. If you consider schizophrenia, for instance, or depression, there's so much more research in the field. There's so much more funding for other illnesses than for anorexia or other eating disorders. It's been really, really underfunded. I mean, I think just in the last couple of years, there has been one or two or maximum 2-3 kind of grants that have come out with a specific focus on eating disorders. Actually, before most of the cohorts were actually even excluding eating disorders. I can think of a couple of them where I emailed them and asked, could eating disorder be a target? And they said, oh, no, we normally target other illnesses. Probably they have that misconception that it might be not biologically enough. I don't know, but I've gotten that response a lot. So definitely it's completely underfunded. We need more money. It's really, really hard to get the money to do any type of research. All the type of research that we're currently doing is on a really, really, really low budget. In terms of what priorities there are, there would be a lot. I mean, it would be from the risk factor assessment, because as I said, we don't really know who develops an eating disorders and what type of eating disorders. Also from the kind of early intervention, we do have a bit of an inclination what might work and what might not work, but there aren't really enough randomized control studies. Also for new treatment modalities potentially, also at the tertiary level, that's the same. And I think also kind of maybe interventions that can reach out to a wider community, also in Australia to more rural kind of areas. Again, there's not enough money to do that research. So, I mean, for instance, we have a student now that looks at the gut microbiome and the oral microbiome. It's quite expensive. We don't have any funds for that, so we're trying to get funds from our school, but there's hardly nothing in the area of eating disorders in that field. That's just an example I'm giving you. There's lots of examples I could provide you in terms of that. It's completely underfunded. I guess also really, really important to get the consumers' perspectives on it. So the eating disorder clients and their families, and to be able to also kind of do more research on their kind of perspectives, and that kind of helps feed into our research so that we can have kind of co-design. Research is really important, and obviously for all of this you need funding. Otherwise you can't do the work, because one person is not enough to do research. You need people that can help you, and if people participate as well, you want to kind of reward them in a way, which a lot of time people are doing it because of their personal interest, but obviously there's so many resources that need to go into it that you need to be able to pay people to do that. So yeah.
From all we've talked about, Isabel, what would be the take-home from this interview you'd want people to remember the most?
That's a really good question. I mean, I think what you highlighted before in terms of that anorexia and any type of eating disorder is not the person's personal choice. It is a really important and a real mental illness. I think is really, really important, because I think even society hasn't gotten that right, and a lot of mental health care professionals, as I mentioned before, as well. And we do know from our studies that it has a really big biological component as well, even though the social psychological are really big as well. But I mean, to understand that it's not the person's choice. Another, I think, important message is, I don't know if you've touched about it, but recovery is possible from anorexia and any type of eating disorder. So I really think it's really important to be having an optimistic kind of outlook on treatment, and that many people that have engaged in treatment at the right time have really been able to benefit from it, and have recovered and have had full recovery without relapses. So not to get that impression that it's not an illness that can be treated. It can definitely be treated, but the person needs to access treatment. And I know that now with COVID, it's been really, really, really difficult, because there's really long waiting lists and people can't access that treatment. So I would really like to encourage, I guess, the funding bodies to provide more funding to be able also to train clinicians that actually are in any kind of treatment contact with an eating disorder person, to be able to recognize them really early on, and that will be allied healthcare professionals as well as GPs, dentists, and nurses, so anyone as the first access point, that they're actually able to recognize the illness and then to actually provide the right treatment for the person with an eating disorder. So we do really need to upskill our clinicians to be able to treat more eating disorders, because I think at the moment it's a bit of a niche area, and so that's why also there are these really long waiting lists. People might say, oh, I don't specialize in eating disorder, and maybe a clinician, psychologist or so, I refer you on to my colleague, but they have such long waiting lists with COVID that they can't take on everyone, so that everyone feels like they could probably contribute by getting that if they get some type of training in eating disorder. So I guess I'm encouraging funding bodies to provide more training that could kind of train a much larger set of also generalized clinicians who would be able to kind of shorten those kind of waiting lists, and that actually everyone can get access to treatment. I think would be really, really important.
Well, thank you for taking the time to talk with us today, Isabel.
Yeah, thank you. Thanks for inviting me, and that's been very interesting.
My guest today was Professor Isabel Krug from the University of Melbourne. Tune in next week where we talk with a long-time expert in the anorexia field, before we move on to talking with people that have had the condition the following week after. And if you like this content, check out the Wellbeing podcast for more. Thank you for listening. I'm Jack Hodgins, and all of us at Wellbeing wish you well.